Okay, I think we'll make a start. Welcome everybody to the 4th UK Histiocytosis Forum. I think it's the best turnout that we've ever had, and that's entirely due to Claire organising an HLH theme. There's obviously a lot of interest and concern about HLH. So we're pleased to welcome physicians, some family members, as well as some industry people, I think, in the audience there. And I'd like to start by thanking Alan and Overy for giving us use of the premises. He's not around, but we're very grateful for them for providing the room. And also to Histio, here's Peter. He's provided us the room back there. And also to Histio UK, who are a small charity patient advocacy group that have a website. Please go and visit it and show it to your patients as well. Lynn Jackson is the chair at the back here, who's organised the practical things for today and provided the sponsorship, so we're very grateful to Lynn. I think just before we get going, we're going to hear from Paul Pontianis. For those of you who don't know Paul, he has a son who is the most famous histiocytosis patient, Nicholas Pontianis, and in more ways than I can summarise in even an hour of talking. I think he's contributed a lot to histiocytosis research and awareness throughout the world. So thank you, Paul.
Thank you, Matt. Thank you, Claire and Matt, for organising this wonderful get-together. Thank you all for taking the time out of your very busy schedules to be here with us today. I've been trying to understand the histiocytosis since 1981, when my son was diagnosed, in fact, at Great Ormond Street Hospital. And I'm so glad to see so many people here from Great Ormond Street Hospital. He was diagnosed in 1981 with multi-system LCH. He's now a person with special needs because he's been affected in the central nervous system. And I think Histio UK is the brainchild of a great doctor who was at Great Ormond Street. Some of you may have met him or know him, Dr. John Pritchard. It was established in 1982, and our motto is that we're developing, of course, is trying to find a rational cure. Nobody dies from histiocytosis, and we are trying to develop a rational cure. So we've done a lot of work on this over the years. This is a small organization, but it is very focused. We brand ourselves as histiocytosis. We do nothing else. We do not want to be hijacked by large fundraising organizations, because we think that we will lose our identity and our focus on this. We also organize a symposium every year in Greece, called the Nicholas Symposium after my son. We have done great progress regarding understanding LCH on that one, and now I think we're going to focus on HLH more than before. So we are small, we are focused, but I want to tell you that there's very few people around the world that are even peripherally involved in the histiocytosis, either from a parent point of view, or a patient point of view, or a medical practitioners, researchers, who are not part of our extended histiocytosis family. So I welcome you to it. Thank you very much for coming. And again, thank you, Claire and Matt, and Alan and Overy, and Lynn Jackson. Thank you.
Okay, so the agenda today is going to be a little bit agile. So the non-immune people are not able to come today. So instead, Anu is kindly going to show us a few slides of the non-immune data instead. The break will still be at 3 o'clock, but we'll just kind of be quite flexible about what we have before and after that. So we tend to have a theme for these meetings, and this time it's HLH. Last time we did some HLH and molecular medicine. This time I think it's more about trying to get some cohesion between all the different groups of people that work with HLH patients, the rheumatology teams, the adult physicians, the transplanters, and really to try and see what we can learn from each other. So I'm really grateful for Dr. Nathaniel Abaidi from Great Ormond Street Hospital. So he's one of my rheumatology colleagues there. So the rheumatology colleagues in our institution have been using biological treatment for HLH and macrophage activation syndrome for a long while. I think we've got a lot to learn from their experience. So he's going to share some of that with us today.
Yeah, thanks, Claire.
Thank you.
Okay, thank you very much. So just to disclose, I know in the program you have the spina diphtheria. So she started the talk, but she couldn't come, so we finished the talk. We are talking about secondary HLH, macrophage activation syndrome, which is a severe and potentially fatal complication of various conditions, but really I'm going to concentrate in my talk, since I'm a rheumatologist, I'll talk about I'm going to concentrate on inflammatory conditions, in particular systemic onset juvenile idiopathic arthritis, or the adult type is the Still's onset disease. We have other conditions, lupus, Kawasaki, and of course there are various infections, metabolic conditions, malignancies can be complicated, or even drugs can be complicated by macrophage activation syndrome. Mostly I'm going to talk about, all the data will be mostly about systemic onset JIA complicated, or autoimmune diseases complicated by macrophage activation syndrome. It is rare, it is fatal. The mortality rate, if it's undiagnosed early and untreated, is really high. It's 20 to 30%. I don't know how many conditions you know with such high mortality rate. So I thought we're going to talk about the biologics and the targeted treatment, but what's important is to pick it up. You pick it up early, you treat early, usually your outcome is better. The thing is, with the inflammatory condition, it can be difficult to distinguish between macrophage activation syndrome and the systemic onset JIA. So we have to pay attention and to look, actually, to hunt for it, to see is it happening now. So in the past, we relied on the HLH protocol that you do, the familiar HLH. So the clinical features, the non-remitting high temperature, hepatomegaly, splenomegaly, lymphadenopathy, hemorrhage, and central nervous system dysfunction, and of course the laboratory findings, the cytopenia, abnormal liver function, coagulopathy, in particular low fibrinogen and high D-dimers, falling ESR, high triglyceride, high ferritin, hypoalbuminemia, and hyponatremia. Since then, so the pediatric rheumatologist, the problem is that with our condition, so if you think about the platelets, as an example, in our patient, when they are inflammatory, the platelets is sitting 700-800. So when it drops down to 400, 300, this is falling. So you follow the trend. So having a platelet dropping from 900 to 200 is bad news. Although 200 is not too bad, you would think, but dropping is, this is just as an example to why it can be tricky. So the Pediatric Rheumatology International Trials Organization, with the three main big groups, sort of at international level, started to look at evidence to trying to propose diagnostic criteria, and it was done sort of in two stages. So the first one, they did a survey contacting 505 pediatric rheumatologists, and they, following literature research, they picked up 28 features in terms of clinical features, lab features, and histopathological features. And they asked them to rate, out of the 28, pick up 10. The number one will give it 10, and the one at the bottom is 1. And the highest number will be, and just to see what clinicians would choose. So we had 9, so out of the half of the people responded, of the pediatric rheumatologists responded, and then we had 9 items selected: falling platelet count, high ferritin, evidence of macrophage in the bone marrow, high liver enzymes, falling leukocyte, high temperature, falling erythrocyte, and low fibrinogen, and high triglyceride. Intentionally, to start with, they did not ask for number, so they did not specify number. And then they went on and reviewed the proposed guidelines, and they look. So although you would think the level of evidence is 3 and 4, there's a professional opinion, but really this is data driven. So they looked at big number of patients, and they looked at the proposed guidelines, and they looked at specific numbers. And now we have this diagnostic criteria for MAS in systemic onset JIA. That's what rely on, of course, what we need a prospective study to validate it. But that's what we've been using. So patients with systemic or suspected JIA, temperature and high ferritin more than 684, and 2 of the following: low platelet count, high AST, high triglyceride, and low fibrinogen. Now, in terms of the genetic factors for MAS that can be similar to the one in the familial HLH, there are a few studies looking at NK cell dysfunction. It's been common in the end, and they compared there's in all the small series looking at the NK cell dysfunction, comparing it with the systemic onset. It was more with the MAS. Perforin gene mutation linked to MAS in systemic onset JIA, and the MONC13 polymorphism linked to MAS in systemic JIA. To be honest with you, with all these studies, we are not very clear about it, because is it going to be familial HLH? I don't know. The other thing is, now we've been having case reports of auto-inflammatory conditions associated with macrophage activation syndrome. So all the time, when your child behaves in an atypical way, do think about monogenic cause. So this is, as an example, from a patient who has picked up to have NLRC4 inflammasome. I think with the NLR3, you see it in caps. So this patient had rash and splenomegaly, enterocolitis, and kept on having recurrent MAS. And then they did the gene, and then actually they found this gene, and it's being published. This one is another interesting one. So this is type 1 interferon pathway driven by the DNase type 2 deficiency. Two siblings, initially they had neonatal anemia, and they carried on having various symptoms. They are not twins, so there are two years difference between them. So they had membranoproliferative glomerulonephritis in the absence of features of lupus. I don't know, is this? And then they have so they have non-destructive deforming arthropathy and liver fibrosis, and the abnormal MRI scan, which showed patchy subcortical white matter lesion in the parietal lobes. So they seem to be common. People are more aware of autoinflammatory. People are searching now. Whenever the child behaves, they keep on having it, or the presentation is atypical. I think it's worth doing sequencing to see whether you can pick up an autoinflammatory. Now going back to so now we diagnosed the condition. We did the bone marrow. This is not malignancy. We think this is macrophage activation syndrome. If you want to look at the evidence of treatment, really there's no validated evidence-based treatment guidelines on macrophage activation syndrome. There are various case reports. Most of them are retrospective. which is understandable. This is an acute condition, so people find it difficult, you know, to make a study, randomized controlled trial study, as an example. The commonly used treatment, and probably later on I'll go back to this slide just to summarize practically what we do. But there are various case reports talking about methyl steroid. To be honest with you, all of our patients will have all of them will have methylprednisolone. So whatever paper you read about cyclosporin, etoposide, IVIG, all of them had methylprednisolone. And the cyclosporin, there's a good evidence about the cyclosporin working. Of course, with the cyclosporin, you have to pay attention to the encephalopathy and the renal involvement, in particular with some of your patients with MAS already have renal impairment. But actually, there's a good evidence for the, when I say good evidence, as in retrospective case series. So really, this is the evidence that is available for it. IVIG used a small case series, and all of them with methylprednisolone. I think they tried couple just with IVIG, and they had without the steroid, and they ended up having to give the methylprednisolone. And of course, there are some also small case series for etoposide, plasma exchange, anti-thymoblast globulin, stem cell transplant, and blood products. Now, coming to the novel treatment, what to target. So this is, I guess, you know, what biologic to use. We more recently, over the last few years, we've been using the anti-IL-1. When I say anti-IL-1, I'm talking about the anakinra, which basically the biologic that we've been using mostly for macrophage activation syndrome. But interestingly, if you go and read the evidence, so with me, I have to say, we deal with with macrophage activation syndrome almost on a daily basis. If I don't have one on the ward, there's one from a local hospital, one from a different center, one on PICU. So always there's some discussion about MAS. We do use anakinra widely. But if you look at the literature, actually most of the cases are retrospective studies. Now, there's a study from Cesar Ozen's team in Ankara. So they did observational study, which I think this is a good one. So they did observational study. They had 13 patients with systemic onset JIA and 2 with autoimmune disease complicated by macrophage activation syndrome. And they gave anakinra 2 milligram per kilo per day subcutaneously. And the clinical symptoms resolved at median of 2 days. And the lab findings, which I mentioned before, you know, the fibrinogen, the ferritin, so they resolved within a median of 6 days. And steroid treatment, they came off steroid treatment, the median was 10 weeks. 2 patients, they tried to come down with the anakinra, and 2 patients had recurrent of the MAS, so they put them back. But actually, they all did well. And then there's additional literature research looking at the use of anakinra in systemic onset JIA or autoinflammatory condition. There are 35 patients, actually. 35 patients, so it's not all retrospective cases. So 33 out of the 35 achieved remission. Now, this is an interesting study from the PICU setting, and if you look at the group of patients used, not only, so they are critically ill patients, excuse me, so not all of them secondary to systemic onset macrophage activation syndrome, secondary to systemic onset JIA, or some of them actually, if you see some of them, the provisional diagnosis was sepsis, and multiple organ dysfunction, macrophage activation. So they were all critically ill. It's a PICU setting. 8 patients, and they gave anakinra, if you look at the doses, 10 milligram per kilo subcutaneously. We do give in our PICU, we do give this high dose. We give 10 per kilo, in the very sick patients. And you can see the CRP dropped by 67%, ferritin reduced by 63%, fibrinogen went up, and what I found interesting, no infection attributed to anakinra therapy. So, I mean, you know, one of the patients died later on, just before the, survived. I mean, he improved, he or she, I don't know. But then later on was worked up for bone marrow transplant and died before then. But I found interesting that the infection wasn't an issue with those patients. We do now get calls, as an example, from the neurologist for their patients on PICU about the use of the anakinra in various other conditions, inflammatory conditions or potential inflammatory condition. One of the conditions that they started using anakinra is fires that people are still trying to understand what it is. And I don't know, so far my experience with infection hasn't been a problem. I'm not saying that you should give it in active infection, definitely not, but it seems to be, we need to look into it. Now, this is a problem. Our patients who have systemic onset JIA, so not complicated, the systemic onset JIA, usually one of the medications that we use to treat them is anti-IL-6. The problem with the anti-IL-6 is a great medicine to control the systemic inflammatory condition, but it dampens your inflammatory response. So you don't get high CRP, ferritin initially modestly elevated. The cytopenia usually to start with is quite mild, and maybe afebrile. So with this patient, and I was talking to Kimberly earlier on, there are the group of patients that we need to look into whether to find a way to watch them, because when they develop the MAS, they don't have their clinical features. So basically, we just need to keep in mind if a child with systemic onset JI starts to behave differently or there's subtle changes in their blood count, we should consider macrophage activation syndrome. Now, the other targeted approach is, I think it's very exciting. Now, blocking the gamma interferon, and so I'm a co-PI with Paul Brogan. We have a trial, the Novimmune trial. This is the last slide, I promise. So I was hoping the Novimmune team will come, because I was thinking it's really a new thing. So basically, this trial is for a drug called amapalumab, which is a gamma interferon inhibitor, and it's used specifically for MAS. And we recruited 2 children, the first one with dramatic response to treatment, and the second one, which I told you I'm going to go through how we treat a child with MAS. So basically, this child had methylprednisolone somewhere else and had multiple pulses, in fact 3 pulses. When I say pulses, high dose of methylprednisolone 3 days, 3 times within 2 weeks. Still no response, so we added anakinra, suboptimal response. We doubled the anakinra dose, suboptimal response. We added cyclosporin, suboptimal response. So really, this group of children, luckily, we have more children responding to the anti-IL-1 and the other medications. So with this group of patients, we really need to think about a new pathway to manage this. So now with the gamma interferon, it seems to be working. There will be another one starting soon for JAK inhibitors. I'm hoping by next year they will be available, and it's more sort of a practice. I think that's it. I was hoping at this stage the Novimmune lady will come and talk about the...
Okay, thank you very much.
Okay, thanks.
Yeah, I'm not going to let you get, just because I think there may be some people in the audience who might want to ask you a few questions. And actually, instead of the Novimmune people, Anu Rao has kindly agreed to show a few slides regarding that, but for maybe 5 minutes or something. Yeah. But if anybody's got any questions, Nikki.
So how do you decide between all of the different possible treatments?
Yes. So to start with, well, you assess how sick is your child and how sure. First of all, when we have them, the first thing we think about is infection and malignancy all the time. So we do the bone marrow, and then we start methylpred.
But out of all of these new treatments, which
Yes. So what's available now is only steroid, anakinra, and cyclosporine. That's what's available. The JAK inhibitor hasn't even started. The trial hasn't even started, and the anti-gamma interferon is a trial. So literally, we recruited 2 children, and I think with the familial HLH also, I don't know, they recruited probably 2. So this is new. It's not available. So what we do.
what would you predict would work best?
I can't predict just from 2 patients because it's international trial, and I'm waiting to see what's going to be the outcome. But it's very positive. I think it's
The interferon gamma.
the interferon gamma. I mean, so far it's 2 patients. I can't make judgment from 2 patients. But of course, and you remember you are dealing with children, and then you're blocking the interferon, so you have to constantly hunt for viral infection and reactivation of the viral, and that can kill the child. So it's how to get it right. But with the 2, it seems to be very positive. We're very excited about it because it's
Is it
good.
better than anakinra?
Anakinra is really good. It's safe. Well, I mean, it's not good because later on when you give it, it's a daily injection,
Yeah.
and you see the response is dramatic. So anakinra, I think, will stay. It will be if the anakinra would fail. And actually, the other group I'm thinking about, sometimes we have monophasic MAS. So they come, the child is really unwell, they don't fit with the systemic onset GI, they just have temperature, maybe a bit of rash, no arthritis at all, and MAS. And you investigate, you look for cancer, you look for infection, you don't find anything, you give them medicine, and then they get better. And then the question, how long should I treat for? With the anti-gamma, it's a course, and you finish it, and that's it. And then after that, you start to treat your systemic if it's there. But if everything gets better, maybe this group of children, they won't have to have the full 1 year or 18 months or whoever you talk to, and they have just to make the judgment how long.
I think there was another question, 2 questions, one here.
So I'm Jessica Vance, I'm an adult rheumatologist 2 miles down the road from you, we've never met.
You have now.
Yeah, we have now. So we do the same kind of thing that you do, also in a not very evidence but mixture of experience and literature-driven way. And etoposide you don't use anymore, is that what you're saying? Because we would, and we would rather
do.
not, we use anakinra first, but we still would.
We do. So as an example, the child that I gave as an example that we end up using anti-gamma interferon, and we recruited, it would have been, the next step would have been etoposide.
Right.
So normally we get Anu or one of you guys to say, can you help us give the etoposide? But yes, we do.
Sorry,
We do. There are some case series about the evidence of etoposide actually. Not many, there are probably 2 or 3, but with other medications. I'm talking about the MAS, not the familial HLH.
And can I just ask one other thing,
Yes.
which is that, is it not a false distinction to separate macrophage activation syndrome in children with systemic JI and adults without onset stills and lupus from HLH, not from primary HLH like SEP, but is it not a false distinction? And
Oh, I agree.
I think we're doing
Yes,
ourselves
we
a
agree.
disservice
It's a
by
hyperinflammatory syndrome. What do we?
Yes.
Who's the EC with me? Help me out.
No, I agree, and now, I mean, we work together now.
Yeah.
GOS Despina and Paul, I think, sits with you on
Yeah.
the HLH committee.
Yeah.
So yes, the short answer is yes.
at UCH we're doing the same thing.
Yeah, Ben's talking later,
Yeah.
yeah.
So yes, we agree.
And sorry, I'm an adult haematologist Imperial. So.
Ronan, you got.
So you,
No, wait, have Ronan first.
Thanks very much.
Thank you.
I'm a paediatric immunologist in Dublin. So we've used anakinra as well in very sick kids with MAS. I'm just interested in how you give the very high doses. Do you split up the doses apart, or do you give it IV? You know the kids that give the 10.
Yeah.
We've given massive doses.
So as I told you, there's no evidence for much. There's not much of evidence. So it depends. The critically ill So the one on PICU, we give high doses.
Do you give it IV or
IV.
You give it
IV. Yeah, we give the IV. We have a protocol, and we use it on PICU only. When they are out of the PICU, if they are, let's say, on 100 twice a day, because once we had someone who was 15, so we gave it twice a day, and then by the time the child was better, or the young person, we switched it to once daily.
Thank you very much. And then the other question, I know you mentioned that you can sometimes mask H&H or MAS in patients who are on tocilizumab. If they don't have the cytopenia, if they don't have the fever, if they don't have the sleep, how do you know they have?
You don't, and sadly, yeah, no, you don't, and sadly, by the time they start,
Yeah.
Actually they are the sick one, and they are the ones that we lose.
So the features did you see are
That we lose.
first spacing or what clinical features?
So clinical feature, they start to change. So basically, they start to have new symptoms: tiredness, maybe a bit of temperature, reported temperature, and you see subtle changes, really subtle changes. So you don't see the dramatic change of platelet from 600 to 200 or 150, but you see there's a trend, and there are some symptoms. Sometimes actually they do have temperature, but the temperature is not that high. It's not the constant high temperature. Unfortunately, I mean, we have children who were on tocilizumab, and by the time they declared themselves, it was difficult to control.
So do you use bone marrow?
There's lots of questions on this.
Do you use bone marrow would you use a bone marrow to look for hemophagocytosis?
You do, but remember, 50% of them won't have it. It helps if it's positive.
Makes you feel better. If you
Yes, it helps if it's positive. But yes, the answer is you do. And I was asking Kimberly. Actually, there are studies. Sorry,
You've got more questions over the slide as well.
So there are studies looking at the level of cytokines to see if they can differentiate. And some of them, although it's very small case series, two actually both from Japan. One saying is the same in systemic and MAS, so it's not going to be helpful. Another one saying, no, actually, there's a difference, the IL-18 and the IL-6, and they gave actually one of them confidently just for 4 or 5 cases, I think, and they gave a number actually to say, this is think about macrophage activation syndrome. And I think Kimberly will probably will talk about it as well.
I said the agenda is going to be agile because I think this is really important to have these kind of questions and discussions at the time when it's fresh. We will, don't worry, we will fit everything in. But so you had a question.
I was going to ask for clarification on how bone marrow biopsy changes your decision making, but I think what you're saying from the previous question is that it doesn't actually change.
So two things. It's helpful at the start because remember you have a child who is very unwell with deranged blood, so we always worry about malignancy. So this is one thing, and we were caught in the past with children initially presented like this and later on had the blast cells. So this is one. The second thing, if there's evidence of HLH, but really the HLH itself, sometimes it shows. I had experience with a child who was not, the HLH wasn't significant on the ferritin and the fibrinogen and the rest of it, but it was significant on the bone marrow, and then within 2 days the child went off significantly. So the important at the start, when the child, you are not very clear about what's going on, you do the bone marrow because you're going to throw lots of immune suppression. This is one. And the second thing, if it's positive, it helps with the diagnosis.
But provided there's no malignancy, it doesn't actually influence your decision
No.
about what therapy to use.
No, because if you look at the on the diagnostic criteria, actually, no, it's not there. So you have ferritin and you have temperature, and you need to, and if you know it's the so the AST and the triglyceride and the fibrinogen.
And how often do you turn up the malignancy in children in that setting with those markers that you've
How often?
How often? Like, ever?
Yeah, once every few years.
Yeah, I mean, personally, I had one that came to us. I mean, it was MAS, but was atypical. Actually, no, two. Another one was lupus with MAS, but the lupus was very atypical, and this one we had to do the bone marrow twice because never behaved normally. The second bone marrow picked up the blast, and then the same day had blast peripheral.
Okay, do you have another question?
Yeah, it was just I was really interested with the comments of people saying that they were teaming up to make an HLH committee or something. So there was a guy in the States presented at Histio Society. They called it an HLH task force, and they seem to have everyone in their hospital involved.
Yeah.
So I think I'll be just interested to hear who people put on their HLH. We'll call it a committee because it's English.
So we've got,
so you have ITU, you have rheumatologists.
no, we don't have ITU.
You don't have, because
We do.
if they had
We do.
ITU, some people would turn up to ITU with crashing liver failure.
Yeah, I think if you can involve ITU, it's really useful because it might be the first point of call if you avoid the acute medic somehow,
Yeah.
because the thought of it. Well, UCH, we have ITU, infectious diseases, virology, haematology, rheumatology.
That's a task force.
I think our system is
Immunology,
our
yeah.
general sort of hospital infrastructure
Alright.
is different, which is perhaps why we don't involve ITU so much. But
And then, practically speaking, how do you
and genetics
manage
we
that?
have.
Yeah.
Because you have to do
We
it.
have lab and genetics. because
You have to do it quickly,
So we tried to get an email, an imperial email.
Yeah.
So the idea is that everybody
So we
in that
have
team would see the patient at this very quickly.
So, for us, it's whoever they're referred to, and then they'll be discussed in that forum, or if somebody feels it's more appropriate for, actually this is feeling like something else, then they'll get that.
So, Rachel Tattersall did the national survey for anyone with ferritin more than 10,000, and it was fascinating to see the conditions, the specialties.
Yeah, so I work in Sheffield and we have a HLH-MDT, which is immunology, ITU, rheumatology, haematology, and infectious diseases. And I'm an adolescent rheumatologist, so I worked with Bethana for some of my career in paediatrics, and I thought in adult medicine, where is this condition in adult medicine? And then I looked, been post about 10 years now, and it's really common in adult medicine if you look. So there are lots of ones. We have an also email list, and we have a once monthly HLH-MDT where we just discuss the difficulties. There are believers and disbelievers in the importance of HLH and how to treat
Yeah, we
it.
include
So
our renal teams. And chest as well. So I think deciding on TB treatment or not as well early on is really important.
What does that mean there are believers and disbelievers in the importance of HLH treatment?
So I'm one of 11 rheumatology consultants in a very collaborative team, but rheumatologists are happy to accept that there is hyperinflammation contingent on inflammatory disease, but they don't believe there's a role for rheumatology in treating hyperinflammation in other situations, and they don't really believe that HLH and MAS are the same thing, and that is not an uncommon. So I think those of us who kind of believe and get it and work together, but there are whole swathes of the country where this is not even thought about or an issue, and people really say, you're just making a mountain out of a molehill, and what do you mean you want to give the sickest patient on ITU more immune suppression? You're crazy, go away.
I think I'm an immunologist at Federal Centre, and that's exactly the case. You have often different subspecialties with a very different approach, and where I'm at Welfare, there isn't an HLH forum outside of the acute setting, and quite often it's very difficult to get people on the same page. And we have a very sick patient on ITU, and everyone goes and gives an opinion. But often when I don't want to, because Nick is going to talk about this, but actually trying to get people to escalate therapy because people have their own safety zone. And it's quite often difficult to say, actually across the spectrum of this, you now need to move on. People like to stick with what they're used to within what they believe is the driver of this particular entity.
And the best rebuttal to the you can't give anakinra to a sick patient is the Vita Shikori paper, which reanalysed the use of anakinra in patients with sepsis, demonstrated they did better than patients who didn't have anakinra. We've just done there was a HLH, there was a sepsis, steroids in sepsis review from the NICE guidance in the BMJ recently, there's not a mention of HLH in that, although they talked about SIRS type things. So I think even in a document specifically about steroids and sepsis, there was no discussion of HLH. So there are lots of barriers, in my opinion.
Well, it sounds like we've got a lot of like-minded people in the room, so hopefully
Not all the believers.
we'll be able to make something.
We're all believers.
Probably
And
each hospital, it's a different team that's difficult.
Yeah.
Or, you know, and
Yes,
you're-
that's absolutely.
Does,
we have
does it help with
dream
access to
teams
drugs, I
are-
guess? 'Cause, you know, we can get websites on how to sort of get Anakin. Does that help?
That's helped us completely. We
Yeah, so we've just got,
Taryn.
Taryn. So we've just got approval in North
Yeah.
Central London for Anna Kinra, which now we're basically handing the document to anyone that wants it. We can copy and paste and apply to their own funding body, with a view to Rachel doing the main work applying to NHS England. The other thing, just one step backwards, is the people in the room are interested, and the people that come to the MDT are interested.
Yes.
And the big unmet need in adult service is acute take, multi-systemal failure, sick as a dog, and no one even thinks of it because no one knows about it. So I've been on a mission to go to medical registrar training days and talk about this, and I think that part of what we need to do is get out of as adult physicians. I think it's so much better
It's
known
not,
as paediatricians.
because I do the diagnostics for most of the country for primary HLH.
Yeah.
I know it's coming through, and I can plot where we get samples.
Yeah.
And there are bits of the country
Really
that
interesting.
apparently have no HLH.
Yeah.
Now, I don't believe that because we see it every ethnicity in every group. And I write letters every now and then saying, you know, do you remember we offer these? And, you know, they just apparently don't have HLH.
So Kimberly can give you the areas of the UK that
Okay,
don't
yeah,
have
yeah.
it. You can target your
And I'm not being
education.
smart, by the
But
way,
it
because, you know,
is, yeah, it is.
being a med reg is a bloody difficult job, so it's
Yeah.
not that. But we just need to get people to ask the question, because it might well be that a bit of steroid early on in some of these patients
Yeah,
can really
it can.
turn things around.
So it sounds like, sorry, I'm not taking over your chairperson role, but out of this meeting will come some documentation that you're willing to share with me.
Well, I'm
Great.
glad you generated this.
Thank you so much. Okay, so. I know we're running a bit behind, but we'll be okay. Anu is Anu Rose, a consultant haematologist at Great Ormond Street Hospital, and has had a long-standing interest in HLH. So she's very kindly going to give us a few slides about the non-immune trial that's open at Great Ormond Street.
I've got 5 minutes, right?
Well, yeah.
Okay, fine. So
See how agitated Kimberly is.
I was going to, if you don't mind, I'm going to sit down because otherwise standing up seems a bit too formal. But I was planning to just start off with slides on Novimmune because this was the new treatment in HLH. But I just thought I'd start with 2 slides. One was exactly what we're all talking about now, which is we talk about primary versus secondary HLH, or genetic versus non-genetic HLH. And this paper that was published in British Journal of Haematology is actually encapsulates all that we were talking about just now. HLH is a perfect storm. What you need is a genetic risk, plus inflammation, immune suppression, or immune dysregulation, as we'd like to call it, with or without an infectious trigger, in varying strengths, leading to uncontrolled hyperinflammation, cytokine storm, HLH. So HLH is actually a conglomeration of symptoms and signs, where at the end of the day, you could actually have the same symptoms and signs in a patient who's got meningococcal septicemia. You have a known bacteria, have a known virus, you treat the bacteria, everything gets better. Or you might have the other system where you have a bacterial infection, but for some immune dysregulated environment, either engendered by a heterozygous, homozygous, compound heterozygous genetic mutation, you then trigger what is an uncontrolled hyperinflammation. How I explain it to my patients, John's there, is that I say that most of us have had a flu, and we know how bad you feel when you've got a flu. But the fact that you get a virus coming in, your body hurts, your eyes are burning, you can't move out of bed, but you have an immune system that's competent, you do not have a predisposition to have uncontrolled hyperinflammation, you control your flu, you settle down. But there are some patients who run around being exposed to viruses and bacteria for some reason do not have an immune competent system that doesn't switch it off. And that's where you get uncontrolled hyperinflammation and HLH. So I think this is how I think of HLH, that where is my patient in this sort of little vertical block column? Am I going to say my patient is primary HLH So I've got a known confirmed genetic mutation, or have I got something that's infection associated, malignancy associated, or in the context of rheumatology? Because what we're finding is a lot of our rheumatology patients with macrophage activation syndrome, if you look at the genetics, they often do have heterozygous mutations in Monk 18.4, 13.18.2, 13.4, sometimes, I'm not sure about syntaxin 11, but they do have certain heterozygous mutations. So therefore, but that isn't a given. It's a matter of how much you hunt for it, look for it, and identify what happens. So, and this is the whole mutation side of things. And this is the bit that I again speak to my patients about quite a lot, which is talking about patients who have got no mutation, who have very good residual cytotoxic function. And these are the secondary HLHs where all you do is dampen down the response, and at the end of it, you can stop treatment, job done, hyperinflammation over, end of story. Versus the crew that Kanchan and I see, that is, so I'm a hematologist, she's the transplanter, we have these conversations, and I see them over here, and every once in a while we have a gray zone over here. And then the question is, are these mutations monoallelic, bigenic, missense, nonsense, or nonsense biallelic? And this is the kind of thing. So I would say that all the patients that we have seen with HLH at Great Ormond Street Hospital, and that's the only experience I haven't worked in other hospitals or dealt with other patients with HLH, but our experience is, if you had to plot all our patients onto which end of this red and green spectrum, I could probably put my patients and dot them. I know certain patients who are at that end or at that end, and then there's a bit of a gray zone. Yeah? Okay, so now that's it. That's my little spiel on primary versus secondary. And often when my registrars ask me, but how do you know this is genetic and how do you know this is this? I say it is a retrospective diagnosis. Patient doesn't come in through the door with a postcard and says, I have genetic HLH. Patient comes in with hyperinflammation. Your first job and only job is to recognize it, which is the recognition question on, is this sepsis, is this HLH? The second job you have to do is make sure you send all the screening assays to Kimberly, because she is amazing in sorting it out. This was something that Claire Booth, myself, and our HLH committee together formulated, which is send the right tests, which is all of that in pink over there. Secondly is what are your initial investigations that you would do, consider infections. We very, very strongly feel you have to look meticulously, get an infectious disease consult, and look for those infections. Leishmania being top of the list as something that we send PCRs, microbiology, trifines, and everything to find out. We do not rest till we either identify an infectious agent, or if we can't, then we say we are beyond the limits of identifying this. This must be really quite esoteric. But as you can see, these are all the specialties that all sit around together in a room. We all scratch our heads, because even through this exhaustive list, you still come back with, I don't know what's going on over here. That's the bottom line. Okay, so I'm just going to go to the Novimmune study. This is it's called the NI504. There's 04, 05, 06, 09. So there are 4 different studies, same drug, but 4 different studies, different inclusion criteria, different stopping criteria. It's phase 2-3, open label, single arm, multi-center study, and the drug is, I always have problems pronouncing it, imapalumab. I'm just going to call it Novimmune, just so that it flows in. Yeah. Okay, and so it's a human anti-interferon gamma monoclonal antibody in pediatric patients with primary HLH. So this is an interesting thing, because like I said to you, they don't walk in through the door and say, I have primary HLH or genetic HLH. They come in with HLH. And that's when our conversations with the rheumatologist, with the immunologist, and all of us start to say, how likely is it? Is it just by age of onset? I've got a 9-month-old, a 14-month-old who's coming in with this, so it's probably genetic, but we don't know. We go by what we suspect might be going on. The study population, that's what I've said, primary HLH, but they don't walk in through the door telling you they've got that. The important thing about this study, and this is the new thing about this study, is it can be used in treatment naive, so as first-line drug. This is a big call for hematologists, because for 20 years we've been using steroids and etoposide, HLH 94, HLH 2004. Nothing's changed. It's been steroids, etoposide, cyclosporin, 3 drugs. And the point is, the moment somebody said you use it first line, you say, well, we have a standard of care. We know that works for 20 plus years. Why would we try something new for a phase 2-3 in an incredibly sick patient where I haven't got any efficacy data as yet? So it's quite a scary thing to do, but there is data. 34 patients so far have been treated. 7 of them have been treatment naive, and all have had a very good response. So it's quite interesting, and it's watch this space till we get more information on these patients. Most hematologists around the world, I'm only talking as a hematologist, not as an immunologist and not as a rheumatologist, because that's not my area of expertise. But as a hematologist, most people will be comfortable starting it as second line. That is either on disease reactivation or when you have a non-responding patient. So most of the data is, out of the 34 patients been treated on the Novimmune study, 27 have been second line, 7 have been first line. And 2 of those 7 are our patients together. So how do you define primary HLH? Molecular diagnosis, or you satisfy 5 out of the 8 HLH diagnostic criteria. I won't go through this because you've seen the slide already and you know what this is all about. Remember, you don't need to have all of it. So very importantly, very early on in my career, I learned that you do need a marrow to exclude malignancy. You do need a marrow potentially if you want to exclude an infection, probably a parasitic infection, leishmania, but you do not need a marrow to confirm a diagnosis of HLH, because you can have rampant HLH, but a bone marrow that you could barely see one macrophage, and you think, is that it? But I've got a sick child over here, and that can happen. Yeah? 18 years or older. This is the study design. And if I might just show you what a standard HLH therapy looks like, because that study design becomes more sensible. This is what we've been treating for 20 years. Vasanta knows all about this because your PhD was on it, wasn't it, Vasanta? So essentially, you have steroids, which are given as dexamethasone, which is given for the... no pointer, is there? Sorry. Is there? Okay. Great. And what do I press? That one? So this is the important bit, and the reason why I'm going through this is not like a tutorial, but I'm trying to explain why the Novimmune product we're all excited about it, and that's the bit that this standard of treatment brings home why this new treatment is so exciting for us. Because we give 8 weeks of steroids, starting at 10 milligram per meter square of dexamethasone, and at 2 weeks stepwise, we bring that down. So remember, this patient is being exposed to 8 weeks, that's 2 months of high-dose steroids. What you get is a grumpy, irritable, fat child who eats all the time and is unhappy. And you have to tease out how much of this is disease, how much of this is dexamethasone-related toxicities. Yeah? You've lived this, so you know. And then after that, at 8 weeks, historically, what we used to do was, if we ummed and ahed and thought this is probably secondary HLH, we'd stop at 8 weeks and we'd watch and we'd see. And most of these patients would suddenly start reactivating the disease, and we'd say, this is primary HLH. I don't have a genetic diagnosis as yet. I may have a screening assay which might help me, but I don't have a confirmed genetic diagnosis. Child's proving it, child's screaming out, I've got HLH, you stop treatment, here's my disease, give me a transplant. And that's what we do. Whilst we're waiting for the transplant to happen, we are doing this. We don't stop and say, oh gosh, can we get the transplanters? Because the transplanters are furiously trying to find a suitable donor and an easy and a smooth transplant. So our job for the transplanters is keep the child in a continuation phase of treatment and make sure they have as best controlled disease as possible. Sometimes it's not a happy story of continuing like this. You kind of stop here, disease reactivates, you go back over here, so more exposure to steroids, more exposure to etoposide resulting in cytopenias, low neutrophil count, increased risk of bacterial infections, child stays in hospital longer. So once you start with HLH, what you're predicting for that family is, I used to tell them, you're not going out of this hospital for 3 months. In your mind, 3 months, you're in hospital. As much as I would like to send you home, a well child, I don't think I'm going to be able to do it, because the side effects of the steroids, the cytopenias, with the etoposide, and generally a child not being well is what's going to keep you in hospital for 3 months, is what I would say. And anything less than that is a bonus, is what I would tell families. So now to make this clear, same sort of story. Can you see that magical number oh God, I'm never good at this.
8 weeks.
8 weeks. Thank you. So there's the week 8, right? So this is why that magical number of week 8 becomes important. Because what the Novimmune product is doing is there's a treatment period 1, which is 2 weeks, and there's a treatment period 2, which is week 3 to week 8. The infusions are quite intense, every 3 days, and then it's twice a week. And then you go into what we would call a continuation phase or a weekly medicine. The important thing about this is, look, no etoposide, so chemo sparing, which is the loveliness of hematologists hate giving chemo, although that's what we do all the time, but we don't give chemotherapy, number 1. We do not give cyclosporin, so we're lovely, no problems with hypertension, no problems with renal toxicity, no problems with checking cyclosporin levels and all of that. You do give steroids. But the important thing was, this is what I needed to see in action, because they said to me, this will potentially reduce the duration of steroid exposure for your patient. And I said, yeah, I really need to see that to believe it. I'm not really sure I'm going to see that. I've had 2 patients so far, and I've been able to come off steroids within 2 weeks instead of 8 weeks. Now, these are my 2 patients, and that's the question that I would be asking the Novimmune people, which is, how long were your patients exposed to steroids? Because if they say it's 8 weeks and we didn't make a blind bit of difference, there's still the toxicity of steroids that you're dealing with. But right now, what I would say is, in my 2 patients, I've been able to come down on steroids so quickly that my patient is out of the hospital by week 3. And that is amazing. I was telling families 3 months, and now I'm telling them week 3, week 4, you're out of the door. Which I think is nice, but this is the kind of data that I want from Novimmune, that I'm trying to get to. What was the duration of hospitalization? What was the duration of steroid exposure? What were the toxicities of treatment? And those are the questions I need answered for me to really feel this is something great. I have n equals 2, they have n equals 34, right? And this is how intense it is, because literally these patients are literally under a microscope. They twitch, and we know it's that important for us. So every 3 days, we give these sort of doses, the study day 3, 6, 9, and 15, lots of those parameters. How do you decide what's the dose? Because you can go from 1 milligram to 10 milligram per kilogram, and what we do is all these parameters. So you can see this is no mean feat. This isn't like an end of the bed analysis. Oh, child looks good, that looks fine. There's a whole bunch of algorithms on what's the platelet count, neutrophil count, ferritin, splenomegaly, coagulopathy. What is it, which therefore determines whether you dose escalate or stick at the same dose. And interestingly, both our patients, mine and a colleague of mine, Sarah Garashian's patient, both of our patients have stuck at 1 milligram per kilogram, which is quite interesting because they haven't had to escalate and they've had good disease control. Again, another interesting point that needs to be asked. So, and look at that, after study day 15, patient condition allows, go home, which is, wow. I had to see that to believe it. I couldn't believe it, but I'm impressed with my 2 patients that we've had. And then this is again, so you do give steroids, 10 milligram per meter squared, and like I said, it can be tapered depending on patient's condition, and certainly both our patients have allowed us to do that. Important thing is infection is because it's an anti-interferon gamma antibody, you have to worry about infections by TB, encapsulated organisms, etc. So we just have to make sure that our patients are screened actively at diagnosis and at follow-up. Duration of treatment. So remember, when we started off, we said it was an inclusion criteria of primary HLH or genetic HLH. So if by week 8, which is quite an ask, which is 2 months, I have a confirmed genetic diagnosis, I will not be stopping treatment. I will continue treatment and ask my transplanters, please can you get a donor sorted and everything done in this scheduled ASAP. However, if by week 8 I have no information on genetics because it takes time to get that information. Yes. So at week 8, if I have a confirmed genetic diagnosis, I continue with it to transplant. If by week 8 I have no confirmed genetic diagnosis, I'm thinking this is possibly secondary, maybe, I'm not sure, I will stop treatment. And therefore the Novimmune have an 05 study which allows you to take the patient off treatment and monitor. And obviously with the proviso that if they reactivate, I want access to that drug. And they have agreed. So I said, you're not taking them off and then saying, oh, well, sorry, you made a decision, because I don't know till I actually test my decision out. And so they have obviously agreed, because it's unethical to take someone off and not offer it back again. So they have said, yes, of course, if the disease reactivates, you can have it. It's not in the study protocol, it's a protocol violation, but yada, yada, we're going to give it. That's it. So this is what's important to see. And the way we both are working across the hospital is we're treating primary genetic HLH or suspected primaries. All the systemic onset JIAs are being treated by the rheumatologists on the 06 study. We join up together for the 05 study, where their patients and our patients are followed up on or off drug, and then we see what happens with them. And then there's the 09, which doesn't allow all this little gymnastics, where we just have a continuous study. That's it. Last thing, I don't think I'm allowed to show you the data because it's a late-breaking abstract for ASH. So I think the company might be a bit miffed if I show it, but I have the data which says, very interestingly, that the response rates and survival to transplant, not post-transplant, because not all of them have reached transplant, is almost is 80 to 90%. This is for patients where it's being used as second line. So remember, those are the patients where historically we would have said these patients do really poorly, in the sense they probably have a 60, 70%, and a lot of that depends on, this is Kanchan's area of expertise, in terms of what is the disease status at transplant and what is the outcome post-transplant if you have somebody who has failed upfront therapy and their outcomes are not good. This particular cohort on 34 patients, it seems to be whether they're treatment naive or a salvage, they have very good outcomes. So we're talking 80, 90%. So it's interesting stuff, but these are still small numbers.
Well, thank you very much for stepping in. I don't think we're going to have any questions at this point.
Yeah.
We'll, I'm going to liaison perfectly to Kimberly, who. So I think most of us who work in HLH had this idea in our head that all of the HLH protocol with the etoposide and steroids and cyclosporine and everything was quite heavy hitting, and if we could do targeted therapy that would spare toxicity and would also reduce the time in hospital, that would be great. And then the idea was, well, how do we target our therapy? Well, if we can just measure all the cytokines and we can use one of these amazing biologics or something to target our therapy, then it would be great. Okay,
I'll figure out how to get it.
Do you want to go and find that?
It says entering power saver mode and no signal.
Good. So I think our idea was that we'd be able to send off some blood as soon as these patients came in to get a cytokine profile, which would then allow us to target our therapy.
It's sitting on the hard drive. It's on the desktop.
However,
it just needs to be able to see the desktop.
Kimberly's going to tell us whether this is actually practical and even useful. Well, she was going to.
Well,
you can start.
Well, actually, I was asked. I think my title is cytokines practical and useful, and I will talk about that. In terms of genetics, we're getting better at genetics and genetic diagnosis. So we offer protein screening tests that can be very rapid and very useful. I had a very bad week about a couple months ago where we had 5, which all have now been genetically confirmed. HLHs in 1 week, 4 people perforant absent, not only from Gosh, but from around the country. So that's not a good week. If they are perforin deficient, we can get the genetics back very quickly. I mean, I think for both the Gosh, who had a very atypical mutation, and the Irish patient, we got the genetics back in a couple of weeks. The problem is if they don't have an obvious gene to search for, and you're having to put them on a panel or do next generation sequencing, that's much harder, because you're looking at lots of genes, and the data analysis takes a while. With the genetics reorganization, my understanding is as of April 1st, that will be available for all of England. I'm sorry if you're not in England. With panels that will be looking at 300 plus genes. So that will be a very interesting development, but the time frame is still going to be, I think their time frame is 80 working days, so that's what, 4.5 months. So you're going to have to have made a lot of decisions before then, and getting it faster may be difficult.
We can't have a break.
So I was asked,
The guy's on his way.
The guy's on his way. Okay. I was asked to talk about our cytokine profiling, practical and useful. It would be really nice if I had some slides.
Oh, you can plug it back into yours, yeah.
Yeah.
It's back.
It's back. Never mind. That's not mine.
Do you want to do this one?
I could do this one, but let me see if I get mine. Try diagnostic immunology.
Sounds good. Thank you very much.
Excellent. Thank you. Thank you all for your help and patience with that. Okay, so is cytokine profiling practical and useful? Just to remind you what we're all talking about, I'm talking in this case about cytokines. I'm also going to talk a bit about soluble CD25 and ferritin. Cytokines, to remind you all, are small signaling molecules. They're less than 20 kilodaltons. They activate the immune system. We classically think of interferons and interleukins as cytokines. They share common signaling pathways, and this is really interesting when you're thinking about JAK inhibitors, because all of these cytokines are sharing JAK-STAT pathways. So whereas interferon gamma, anti-interferon gamma blocks interferon gamma, an anti-JAK inhibitor will block multiple pathways. That could be good, that could be bad, but that is what we're talking about. Chemokines, they're smaller proteins by definition. They recruit white blood cells. They're chemoattractic cytokines. I'm going to spend a little bit of time talking about CXCL9, partly because Novimmune thinks it's a good marker for interferon. It's induced by interferon. It's a T-cell chemoattractant. I will mention soluble CD25 and ferritin, which everyone knows about. So the talk was practicalities and usefulness. You can measure these easily, but not cheaply. So all the assays are based on ELISA technology. So the cytokine in the serum is bound by an antibody, and you use the detector to detect that antibody, and you measure it. So there's three main assays used. So there's the Luminex system. You can do 25, 32. Theoretically, you could do 100, but no one has a kit that does 100 cytokines. It is relatively costly, and it's cheaper if you can do 96 tests. But they sell it as 96 tests per kit, but you don't get 96 runs because you have to run your controls, you have to run some standards, you have to run all of those. So in fact, you might get 80 out of the kit if you were lucky. Most people like to run things in duplicate or triplicate, so actually you only get 40 out of the kit. So it's cheaper if batched, and that's true for everything. The cytokine bead array is a BD system, works exactly the same way in that you have beads in your sample and a detection antibody. They form complexes that you can detect by flow cytometry. This is a little easier to run smaller batches on, but again is expensive, and the more you run at one time, the cheaper, but you can run it as one-offs. And certainly for the CAR T cells that have nothing to do with HLH, but we run lots of cytokines for CAR T cells, we have run urgent one-off samples, and it's a very doable thing. Obviously, ELISAs are the way these were originally identified. It's one plate per cytokine. So it's very expensive if you want to do lots of cytokines, and again, they're cheaper if batched. You can do all of these. Technically, it's not a problem. The problem is the cost, and the fact that we want to batch them to keep the cost down means you have delayed turnaround times, and you want to know what those cytokines are today, not what they are in 2 weeks' time. We're moving to mass spectrometry. It's under development. We're looking at 86 different chemokines, cytokines, and other inflammatory factors. The big issue is we're still trying to figure out a really good way to remove albumin and immunoglobulins. So if you think about it, immunoglobulins are measured in gram per liter. Cytokines are measured in picogram per liter. That's an awful lot less. So we have to get rid of the common proteins to be able to look for these rare proteins without affecting the rare proteins. So that, at the moment, is the trick for mass spec that we haven't quite mastered, and that's what we're working on. The advantage of this, obviously, is it'll be really cheap, and you don't need a batch, but we're not there yet. We did a comparison at GOSH, actually, for other reasons, between the Luminex and the cytokine bead array. They're comparable. They were both negative for all our negative samples. We defined negative as less than 5 picograms per mil, and they all detected 20-fold increases with comparable values. So I don't think it matters which system you use. This is interesting for later. So this is very replicable of patients who have cytokine release syndrome because they're getting CAR T cells. And what I want to show you is that they get very high IL-6 and very high interferon gamma with a little bit of IL-10. Occasionally we'll see a trace of TNF. IL-4 and IL-2 never go up, ever. But in general, the IL-6 and the interferon gamma almost mirror each other if you look at these graphs. And this is one particular patient, but it could be any of a series of patients. They all look basically the same. In this case, we happen to have given tocilizumab, so everything comes down. So you're giving anti-IL-6, and you're bringing down the IL-6 and the interferon gamma. Just something to think about for later.
IL-2 receptor go.
In these, actually, we haven't measured it. We have some samples to measure. We haven't actually looked at it. I suspect it would. It's a completely non-specific measure of inflammation. So we've done a couple of things. We've looked at across the board, soluble CD25, ferritin, CXCL9, and cytokines in patients with HLH en masse. So both primary-ish and secondary-ish, but on that same spectrum. We also did a study, reviewed 99 patient samples who had ferritin soluble CD25 measured at the same time. This is harder than you think, because people will send a ferritin today and the soluble CD25 tomorrow. So I actually was really pleased we managed to get 99 samples where they were sent within 12 hours of each other, which we called the same day. So that was interesting. What was interesting is if you use the bare cutoffs for elevated levels of 2,500 and 500, which are both, I would consider, low, there is relatively good correlation. 62% both were high, 15% both were normal, but there was discordant in about 20% of the time where you had a normal soluble CD25 and a slightly raised ferritin, or ferritin was low and the soluble CD25 was high. If we went to higher levels, so we use 5,000 for HLH, 95% of those had high ferritins, which is interesting. And the reverse wasn't as true. If ferritin was over 1,000, 81% had high soluble CD25s. However, as that ferritin goes up, more and more have high soluble CD25s. So I don't think, although it's a criteria for HLH diagnosis to measure soluble CD25, if you have a ferritin of 5,000, 10,000, we've had them of 71,000s, all of those have very high soluble CD25s. So I think measuring soluble CD25 is useful in those patients that are just slightly elevated ferritins or normal ferritins, because it may give you another criteria. I don't think it's useful if your ferritin's already at 20,000. I can guarantee your soluble CD25 will be up. So every now and then I get phone calls. We have to know if they have HLH. It's urgent. We need an urgent soluble CD25. What's their ferritin? Oh, it's 20,000. I'm going, you don't need an urgent soluble CD25. I will guarantee it's raised, and we run it and it's raised. So it's nice to have it, but not essential, yeah.
What about as it's resolving? When
the soluble C25 can come down faster, and for some of our patients it is a better marker. So I think it's better for disease monitoring because you see it flicker up sometimes before you see the ferritins go up and other things go off. So for some patients it's a really good disease monitor. I think for diagnostics it's only useful in a very small subset of patients.
Kimberly, sorry if I missed that, but
Yeah.
what's the relevance of a high soluble CD25 and a low ferritin?
These are still patients that will end up meeting HLH criteria. They just don't meet the ferritin criteria for whatever unknown reason. Okay?
They're more likely to be the GI, and they're more likely to be like the rheumatoid.
There could be patients, for example, on IL-6. They could be patients getting other things. We could go back through this data.
It's so sensitive.
Yeah.
It's up with anything.
So we could go back and look at this data, but there is a subset of patients where it has been useful, but it's a very small subset. And basically what I'm saying is ferritin's really high. You don't need an urgent soluble CD25. You may want a soluble CD25 for monitoring purposes, but the odds of needing it urgently are not high. So I did a quick literature review, and these were 3 interesting papers looking at cytokines and HLH. They're not terribly useful in some ways. So this was a study done in 2012. They looked at interferon gamma, IL-10, in a number of patients. They were not genetically defined, but they met 5 out of HLA criteria. So this is going to include primary and secondary HLHs. But if you had high interferon gamma and high IL-6, and these are high, they defined it as very specific for having HLH. It might be primary, might be secondary, but they had HLH. The Swedish group, so this is Yen and Hunter's group, looked during active disease, interferon gamma, TNF, and IL-6. They were elevated in all the patients tested, but they defined elevated as so low that I'm not sure we would have defined it as elevated, or it would be just borderline. When your cutoff is 5 picograms per mil and you're measuring 6.5, it's not exactly, I mean, I wouldn't necessarily call that elevated. I'd call that borderline, and we'd see that probably in a patient with a cold and a flu and lots of other things who aren't 100% healthy. And then this was a study done a number of years ago, but it was interesting. It was a very nice study looking at mRNA for a whole slew of cytokines. And it was interesting because, again, IL-10 and IL-6 had a 10-fold increase in expression levels. These were familial HLHs, so genetically confirmed HLHs. What was interesting is that the patient controls in this study had normal levels of interferons and interferon-inducible genes. by mRNA. It doesn't say anything about protein, but it was interesting because, of course, we're giving anti-interferon gamma because we assume interferon gamma is high. This is very preliminary data from us at GOSH. We looked at 11 patients, from 2 that were autoinflammatories, a couple of XLP, XIAPs, and some HLHs that we don't yet have genetics on. One of them is likely to have some genetic mutations, but we don't have anything back yet. And we looked at ferritin, CXCL9 we only were able to do in a couple of samples, soluble CD25, which wasn't done in every patient, and then the cytokines. Although I'm saying less than 50, because that's where our technical reporting range cutoff is, anyone that's above 5, I've actually put the values in, although those aren't going to be accurate because I only have 1 point down there on the curve, so how accurate that actual value is, I don't know. What was interesting is a lot of patients had normal ferritins, normal soluble CD25s, normal everything. Obviously, if the ferritin's up and the soluble CD25 is up, we expect that. This was an interesting patient because there's no IL-6 interferon gamma, and they had elevated IL-10, which surprised me. I don't know what that means. I don't know what any of this means, actually. I'm just sharing this with you and how useful it is. This one had a pretty high ferritin, slightly high soluble CD25. Cytokines were flat. This one had a high soluble CD25 with flat cytokines. This one, again, you had a high ferritin, high soluble CD25, high IL-6. And that's sort of what I would have expected to see, although I would have expected to see some interferon gamma. These are patients with EBV-driven HLH, so they may be primary, they may be secondary. These all had high, well, this one had very high ferritin, soluble CD25, high IL-6, high IL-10, and this one actually did have some interferon gamma detected. This one had no increase in CXCL9. The top of the normal range is 180, and this one also had no increase. I would have expected this to be up with a ferritin of 80,000 and a soluble CD25 of 7,500, but it wasn't. By this point, we are detecting interferon gamma, we're detecting CXCL9, IL-6 is off the board, and IL-10 is quite elevated as well. It's 11 patients. I don't know what it means.
So I've always had this question about, we've seen ferritins of 50,000, 80,000. I think it's exponential. After a while, the number becomes...
Yeah, after a while it becomes meaningless. You can't measure anyway. It's being extrapolated from the graph.
Neonates with HSV.
Yep, that's 75,000.
Huh? 75,000.
Yep.
We've had Kawasaki's in the months. So do you think that if you restricted the analysis for cytokines to patients who had 50,000 and above, interestingly, neither of those 2 patients actually had HLH in the sense you treated the CMV, HSV, you treated the Kawasaki, everything settled down. So we were thinking this is going to be genetic HLH. This is a small baby with a ferritin of that, with all the symptoms. Treated the Kawasaki, treated the HSV.
Yeah, I think what we need to do is ideally, it would be great to be able to pull those serums from those patients and run their cytokines. The other one I'd be really interested in is with that leishmaniasis child who was 3 months of age, who had a very high ferritin. Perforin granulase assay, SAP and XIP were normal. In fact, it was a very, very almost over-normal, over-activated granular release assay. But it'd be nice to see if we get the serum samples and run those. So these have just been run on one-off basis, either requested by the rheumatologist or for other reasons, to try and get a handle on what potential therapeutic was done. I think doing a proper prospective study is what needs to happen. And how we fund that is the issue. But I think that would be what would be really useful to do. So what is useful? In our few patients, we're getting IL-6 coming up earlier and highest, and then IL-10. We need far more data for CXCL9. We've run a couple of others a few months ago for a patient that was being considered for Novimmune. We've only had 1 patient where it's been up, but we need to do a lot more to know what that means. What's been interesting is, unlike the CAR T cells, where the interferon gamma and IL-6 are doing this sort of mirror image up and down together, at least in these few patients, we haven't seen that. Don't know what that means, but it's just an observation. I think we could just stop measuring IL-2 and IL-4. I have never seen it elevated in any CAR patient, any of these patients, and what's not being included in here is I have done cytokines on some patients post-HSCT, post-bone marrow transplant, who had all kinds of autoinflammatory diseases, and they would have, some of them have high IL-6 and things, and they still don't have high IL-2 and 4. So I don't think those are useful cytokines. I'm just suggesting that. As I said, only 11 very incomplete sets of data. So ferritin's readily available, cheap and cheerful, easy to measure. Do we need the others in real time? It would be really nice to have them in real time, but I don't think that's going to happen until we get them on mass spec, unless it's really urgent and going to affect clinical care now, because the cost of running these as one-offs is so expensive. If you have very high ferritin soluble CD25, I think you will detect IL-6, but I think we need to do that study looking at those other patients. Should we consider other therapies on the results? And coming back to the first talk, is this the reason that those patients on tocilizumab who have MAS, and it probably is pretty rampant MAS, we don't pick up until sort of 48 hours before they die? I mean, that's the reality, because we've been dampening them down, and are they actually tocilizumab failures? Do we need something else? I mean, they are tocilizumab failures because they've presented with HLH, but do you need something else going into that? And how useful are these also in monitoring treatment response? Certainly soluble CD25 in some patients is useful. Some of these others may be useful in some patients. Thank you all, and I'm happy to take questions.
Thing X is very expensive. What order of magnitude are you talking?
If I'm running a single test, it's about 400 pounds. So if it's a child on ITU who's getting 7,000 pounds of tocilizumab, it's probably worth spending the 400 pounds. But compared to a lot of other tests, that's considered expensive. If I run them as a batch, I can drop that to about 230. So it's about half the price.
Can I ask two things? You didn't measure IL-1?
No, we didn't measure IL-1. That was partly because the cytokine panel is a UK, it's actually an ISO-accredited panel. It was set up initially for the CAR T cells.
Right.
So we actually have,
bias.
there's an IL-6 bias, absolutely. So we need to look at IL-1, and we actually have a graduate student, Lindsay Rivers, who's measuring IL-18 on some of these same samples. I just don't have that data back yet.
Secondly, how stable is it? I mean, if you take a blood sample and then it takes 3 hours to get to the lab, have you missed your cytokines really?
You may have missed your cytokines. I think they're much more stable than you think, because we had one CAR T cell patient where we had samples taken Friday night, lab closed at 5:30. No one told us they were coming. I would have arranged someone to come in. Cytokines taken Friday night, Saturday night, Sunday night, and a Monday morning cytokine sample. And maybe they were even higher Friday night, but we were detecting off-the-range cytokines. So I think they, although they are being rushed to my lab on ice for one of the CAR trials, one of the other CAR trials decided to get it to the lab within 4 hours. And we're not seeing any clinical difference or numerical difference. So I think they are more stable than people think. We keep interferon gamma in the fridge at 4 degrees, diluted out, and it's stable for a week.
Would you get more cytokines, say, because you've got T cells just releasing them?
Yeah, you might get more, you're right.
Yeah.
But you might overestimate your cytokines. So you're absolutely
For a worry.
more.
Yeah, it's supposed to be for a worry.
But
you didn't find that?
we did find that.
Yeah.
Yes, it is.
We found that with other cytokines, actually, it doesn't make a difference.
Yeah. So, yeah.
Yeah. Yeah.
Degradation versus, so at least interferon, so we keep in the fridge IL-2, IL-7 for other reasons. Interferon gamma, they're all at relatively low dose, they're all stable for a week in the fridge and media. So I don't think these cytokines degrade that easily, particularly if you're talking about levels like this.
Is there an upper age limit if you've not identified an obvious secondary cause where you would say, right, the patient is too old to warrant genetic testing?
Okay. I don't think they're ever too old. The oldest patient we've diagnosed, or it was one of Mark Layton's patients, was 72. The oldest one I know of is one from Cincinnati, and when Lisa Filipovich was there, who was 76. So the issue is it going to change your management? If they have family members and kids, it's probably really important to make sure you exclude genetic HLH, because that has an impact for family members. If they have never married, have no children, there's no family around, you're not going to transplant a 76-year-old with HLH. I don't think you're going to transplant a 76-year-old with HLH, in which case it may or may not be worth doing. It also depends what you want in terms of timing, because genetics, a full genetics panel is probably going to be about £1,000 roughly, and it's unclear who's paying for it, but it will take you 4 months. Whereas for HLH, I know the protein testing isn't cheap, but actually knowing they have a perforin deficiency quickly makes a very big difference. Or a likely perforin deficiency because they have no perforin or an abnormal granular release assay. You can enter them in Novimmune with more confidence that they're primary.
So you say your student will check IL-18?
Not my student, she's not my student actually, but we do have a, in molecular cellular immunology, Lizzie Rivers is doing IL-18.
So will they check just IL-18 or IL-10 and IL-6 to see?
She's running IL-18, we can run IL-6. So.
At the same time?
Oh, well, on the same sample.
Same sample.
They won't necessarily run on the same day because
Yeah,
the samples increase them at -70.
How often do you see a clearly abnormal granular release assay in adults?
Okay, so genetically defined, so we've done an audit, and initially it was 5%, it's dropped down. So about 3% of what's sent to me, which is sort of an all-comers HLH, we find a genetic diagnosis, so it is low. The flip side is, if you're one of those 3% with a genetic diagnosis, it really matters to you.
So the phenotype assay, how often is that?
Oh, an abnormal bra, if it's abnormal on one occasion, most of those will be normal on repeat. If they're abnormal on 2 occasions, we'll find genetic 70% of the time. How many adults have abnormal bras? 5% roughly.
And you do find genes.
Yes, and from weird places. So Swansea sent me, I'm really impressed. Swansea sent me a sample, and they have a 46-year-old who's absolutely confirmed is a monk 13 for deficiency. And it was an amazing pickup, and I was just really impressed with Swansea for doing that.
But it's just on the bra thing. We have had patients with normal bra, normal perfect, but still have features of HLH. And
Absolutely.
therefore, you know,
yeah, and there's a new gene that Con Boatsing and Vienna is about to publish that is probably one of the missing, it's one of the missing ones with abnormal bras and no mutation. But you're absolutely right, there are other genes out there. We still don't know what FLH1 is. It's still sitting on chromosome 9q.
The reason I'm asking is because, you know, it's quite a lot of effort to send fresh blood, and the return seems to be really small.
The return is really small. The return is going to be 3 to 5%.
Whereas sending the genes is no problem.
Yeah. So if you don't need it urgently, you can send the genes. If you need it urgently to make a decision, a treatment decision, you got to send the proteins.
But it's only going to be 4 to 3%.
It's only going to be about 3 to 5%. And by adults, I'm talking adults sort of over 25. They're not, you know, we're finding a lot in that late teen. I'm not talking late teens because they're more like younger people.
Thank you so much. We are going to run into the coffee break a little bit, but next is going to be my colleague Austin Worth from Great Ormond Street, who's a pediatric immunologist for me with an interest in HLH. So he's going to talk to us about the more recent outcomes of stem cell transplant for primary HLH.
Hi, I feel a bit nervous talking in front of a lot of very serious transplanters who've done most of this work, but I'm an immunologist who has a particular interest in certain primary immunodeficiencies which can present with HLH. So actually moving on from a lot of those discussions and not talking about transplant outcomes, but just we've heard a lot about how views are changing on what HLH is, and I would totally corroborate with everything that's been Annie was saying earlier. But actually, if you think of it from the other way around, if you're thinking about primary HLH, I think you need to be a little bit careful about particularly the concept of familial HLH as a separate disease entity. And I think it's more useful to think of these disorders as primary immunodeficiencies that can present with HLH. And this is the classical list that you've got, but I would say this is, if you're just thinking along these lines, you're going to miss quite a lot of patients. And that's where is primary HLH, where is secondary HLH? Should we actually be thinking about these as separate categories? And this is what I'm thinking about here. So if you're missing this, you're going to miss some other clearly defined primary immunodeficiencies. There are new primary immunodeficiencies out there the whole time that are coming up that you're not going to know about. We've already talked about macrophage activation syndrome, and we're working very closely with our rheumatology colleagues, and the idea of a lot of their disorders and our disorders being separate is nonsense. Everything is completely overlapping. It's just semantics who ends up picking up the patient first. And then we're just beginning to get the concept of this oligogenic disease, where instead of having one primary genetic mutation, you're getting either polymorphisms or 2 or 3 clear hits in different genes that are leading to a very clear phenotype. And we're beginning to pick up at patients like that. You've then got chronic active EBV, which I'm not going to talk about, but that by definition can't be genetic, which is a bit of a circular argument, but undoubtedly this isn't a normal reaction to EBV infection. And then are there patients out there, and if you listen to someone like Jean-Laurent Casanova, one of the gurus of primary immunodeficiency, he would say there's no such thing as an extreme reaction to an infection, it's just an undefined immunodeficiency. So illustrating some of those points, some of our primary HLH disorders have other clear features which, if they were immunodeficiencies, you'd lump them together as part of the immunodeficiency. Clearly, some of these disorders have inflammatory bowel disease, MUNC18-2, ZIAP deficiency, and we've got patients with perforin deficiency who are a long way out of transplant who've had problems with granulomatous inflammation, and I think as we're exploring the wider phenotype of a lot of these diseases, we're realizing they're not just simply a disease that gives you this one clinical syndrome, which isn't what you'd expect. And then it's also worth bearing in mind some of the old primary immunodeficiencies, particularly chronic granulomatous disease, but also Wiskott, even DeGeorge syndrome have presented with HLH. So it is worth thinking about some of those. There's another paper out the last couple of months describing SCID presenting with HLH, which you wouldn't really expect. But then we also have some new primary immunodeficiencies that have quite a high penetrance of HLH being the main presenting feature, and particularly some of the EBV susceptibility diseases, CD27 deficiency, STIX4, ITK. Actually, that's often their predominant feature. And then the other thing that's worth bearing in mind, and what do we do about treating these patients, is some patients who we've seen in recent years and other groups are now recognizing, where instead of having a systemic hemophagocytosis or cytokine storm, you seem to be having disease predominantly in single organs, either the brain, or we've also seen it in other tissues as well. And this is literally, I've just come from ESID the week before last, and there's another new gene that seems to be presenting with a predominantly HLH feature. So when we're talking about how we can optimize outcomes, it's a balance between what factors we can influence or what factors that we're stuck with that are pre-transplant and what we can do about in and around the transplant setting. And I suppose my talk today is largely going to be just trying to feel around where we think those factors go. We've already heard about how important all of these are. Well, what can we do around the transplant to try to improve things? And actually a lot of this comes from historical data showing that patients with HLH, primary HLH, if you're comparing that to other primary immunodeficiencies, have generally done poorly. This is historical data now, but you can see that if you're bearing in mind the T-cell defects include all the SCIDs who present on ITU with pneumonitis, who in themselves only have a 50% survival rate. Actually, they're probably the worst group of primary disorders that we see. And so the Histiocyte Society trials that have gone towards setting up HLH-94, which was the big step forward in terms of survival from treating HLH. However, the follow-on trial, 2004, was quite disappointing in the fact that we really didn't get any great increase in survival following that. And I'll talk a little bit about some of those results here. I know everyone in this audience knows, but the main difference, apart from some subtle defects about how you classify HLH, is the fact that with the newer protocol, I've managed to get these the wrong way round, so that's great. You've got cyclosporin up front, so you're giving more cyclosporin at induction to try to get on top of the hyperinflammatory process. So the HLH 2004 data was finally published last year. Only 50% or just under 50% of those patients had proven primary HLH, and the survival rate was actually very similar to that was seen in 94, with an overall survival rate of 62%. There was a reduction in the pre-transplant mortality, and and about 50% of the whole cohort of patients went on to transplant. You can see here that actually there didn't seem to be any difference from those who had primary HLH and those who had secondary HLH. And I think that's an important concept, because we're still talking about the same disease process. And they went back and they actually picked out the patients in 2004 who would have fitted the 94 criteria, and were able to compare those patients. And actually, although there was a trend to slightly better survival, that wasn't present in the primary disorders. And these are the survival curves for overall outcome. This is the overall outcome for the whole study, and this is using that comparison, showing that there's just about no difference really. And these are the comparisons between primary and secondary. So overall, what we're left with is survival still sitting just above 60%. Which is a bit disappointing really, because that's just about the same as we had on the historical data previously. So what areas can we optimise around this? Well, this is what I'm not supposed to be talking about, but one of the key factors appears to be whether or not you've got active disease after you've had induction, and then whether you've got active disease going into transplant. And if you look at the adjusted odds ratios here, the only thing that was more important with that was going in with a haplo transplant versus a fully matched transplant. And I think that, well, I think the conclusion from a lot of this data is that that is going to actually be the key factor that we can do something about. So one of the areas that's been hotly debated, and I think the area has moved on over the last decade or so, is myeloablative conditioning versus reduced intensity. And a whole series of studies demonstrated high rates of complications, particularly veno-occlusive disease, pneumonitis, other therapy-related toxicity, but also primary graft failure with full myeloablative conditioning. And a number of people, many of whom are in the audience, have presented data showing improved outcome with reduced intensity conditioning. However, there were still problems because of high rates of mixed chimerism in some patients, leading to secondary graft failure, and actually in an increasing number there was this recognition of HLH post-transplant, relapse HLH. And this was a very encouraging study produced from Cincinnati Children's Hospital, which was 40 patients, single centre really used to transplanting kids with HLH, comparing 14 fully ablative transplants with 26 standard fludarabine malflam campath-like conditioning, and showing a big difference in survival, but also a high rate of mixed donor chimerism that required a lot of intervention. And their work moving on from that was to try to look at how they could manipulate the serotherapy to improve the rates of mixed chimerism. And last year, or earlier this year, they've published the study on beyond that, where they've actually done a formalised prospective study looking at using this kind of intermediate timing of campath, which they felt would boost the chimerism. And you can see this is multi-centre, so 22 sites, 47 patients. Almost all of the patients received bone marrow as a donor source. Wide range of different disorders, and they had an inflammatory PID cohort of about 12 patients as a sort of internal control. And actually their initial primary outcome was survival at 12 months, which actually did look very good. But unfortunately, a whole load of them died within the 6 months following that. So if you come out to 18 months, which was the point of publication, actually their overall survival was, again, just above 60%. They did see quite high rates of HLH reactivation, and this is the intervention-free curves, demonstrating very high rates of either second transplant or at least early DLI to try to stabilise the chimerism. And also, interestingly, with this strategy, I think they had really quite high levels of more severe graft versus host disease. And considering this is predominantly a paediatric cohort, levels of chronic GVHD that I think we would find quite unacceptable. Leading on from that, Kanchan had put together a lot of the European data and a lot of, actually this is predominantly data, no, it's European data, looking at whether you can get more sustained high-level donor chimerism looking at peripheral blood versus bone marrow. And you can see clearly from these two graphs, what you're looking for is the darker bars at the bottom here are showing higher levels of high levels of donor chimerism, so the dark bars are greater than 95%. This is with bone marrow as the source, and this is with peripheral blood. And you can see you're actually getting much higher rates of sustained donor chimerism by using peripheral blood. Similar levels of survival, which weren't significant, but you don't get anything free, so there's obviously an increased risk of graft versus host disease. But actually, if you're looking with the matched donors, which is comparing the first two bars here, actually the levels of acute and more severe GVHD, although slightly higher, there wasn't too much of a hit from that. Other centres have turned to other conditioning regimes. Most of what I've presented so far is fludarabine malphalam, and many of us have moved towards using treosulfan-based conditionings for a lot of primary immunodeficiency. And this is a paper from I think last year, the year before, small numbers showing 100% survival with HLH and really unbelievably good outcomes. But again, it's a small centre and it's relatively early data to looking at that. But undoubtedly, I suppose what we're seeing is we're moving away, as we are in a lot of primary immunodeficiencies, from trying to drop the level of intensity of conditioning right down, and are now looking at probably getting better outcomes by increasing the level of myeloablation to get better chimerism. And then just throwing it in, just out last month, there's a large cohort of the Italian experience, which actually, if you dig down into, because they've had larger numbers of patients, they're able to do a fairly extensive multivariate analysis, and of course they don't find any of the things that we think are important coming out as being important. No difference between using treosulfan, busulfan or myeloablative conditioning. Didn't even make it into the model because there was so little significance, and very little importance, no significant difference between any of the sources. So that's all very helpful. What do we know? What can we take further forward? Well, one of the big questions around donor chimerism is what level of donor chimerism do you need for this disease to be curative, or these conditions to be curative? And there's good animal modelling from that suggesting that 10 to 20% donor chimerism should be sufficient. There has been, again, an international retrospective cohort study trying to kind of look at patients who have donor chimerism that came out a couple of years ago. And although this doesn't give us an answer, I think it does give us some interesting data. So this was just over 100 patients with donor chimerism of less than 75% on whole blood. And what they found is that they had 17% of those patients, so 18, had some sort of inflammatory flare, either classical HLH, a partial flare, or 4 patients with isolated CNS relapse. And about half of those relapses occurred in the first 180 days, so almost 6 months post-transplant, but actually the rest occurred later than that when things were really stable. So importantly, one of the things I haven't discussed, because there's very little published on it actually, and it's something that we regularly discuss, is how safe is it to use a heterozygote carrier as a donor? And actually, of these 18 who relapsed, only one of those was a het donor. Almost all the others, either they didn't know or weren't. So this is the plots of the chimerism. These are the patients who didn't relapse, and these are the patients who did have inflammatory relapses. These three, the full circles are whole blood, so we don't know what split chimerism is on this. However, this patient does seem to be a little bit of an aberration, as that they had high-level T-cell chimerism and still had an inflammatory flare. However, if you take those 3 dots out, you are looking at sort of between 20 or 30%, which is when most of the patients fled. Although interesting, there's plenty of other patients who didn't, who were also at that sort of level. So what we can see from this is that there was a clear outcome difference between those who had bone marrow chimerism of less than donor chimerism of less than 30% compared to those who were greater than 30%. And this is survival, and this is event-free survival, so avoiding second transplant or DLI. And another important thing that came out from this was that it appears that CD3 chimerism appears to be a better predictor of relapse than whole blood chimerism. Also, importantly, when we're considering these decisions, of those who had a second transplant, there was a 33% mortality. So it is a significant decision when you're going ahead of this. And of those who relapsed at the 18, 4 out of 18 died. So these are very pretty bars, but I suppose what this illustrates is it's actually very difficult to predict what's going to happen to these patients. So this is time, and on the bottom here, you've got days. These are the asymptomatic patients individually set out, and this is their duration, so their follow-up without any activation. The darker sides are just the stabilisation of the chimerism. This group here, the second group, are those who preemptively had a second transplant before developing inflammatory conditions. And then the bottom group are those who've relapsed. The top 3 are those with those minor flares who didn't go into full HLH, and the bottom are those who've developed more significant flares. And you can see that many of these patients have taken a very long time before they've flared, and many have lived for many years without any complications. So I think that it's incredibly useful in terms of description of what's going on. I don't think it clarifies actually what you do or what sort of level we should be aiming at. The conclusion from the paper is that we should be thinking of 30% as a cutoff, and I think in terms of overall outcome and survival, that's very reasonable. But on an individual patient basis, I think it's quite difficult. So one thing that I think has been clarified in the last couple of years is what we should do with asymptomatic carriers, and this was a paper published this year by Giovanni in our group, led by Kanchan, looking at babies or children who developed a primary HLH and then their parents went on to have a further sibling who we were able to diagnose as being genetically affected at birth or soon after birth, and therefore we didn't really know what to do with them. And 32 pairs were identified. It was a multi-centre retrospective study. And actually, just naturally by how they were managed, they fell into groups. 10 developed HLH while they were being observed, and all of those ended up having a transplant. 16 ended up having a preemptive transplant, so never developed HLH and were transplanted cold, and 6 remain, or at the time of data close, remained under observation without HLH. So this is the survival curve of the index cases, so the children who initially presented, and here you've got the comparison of the other siblings who were well, and you can see there's clearly a survival advantage to having that diagnosis at birth and being aware of it, as you would expect. However, probably more interesting is if you dig down into what's happened to the asymptomatic carriers. And you're looking here, so of those 10 who activated before anything happened, 4 died and 6 are in complete remission after a transplant. And those that had a preemptive transplant, of the 16, only 1 died, and the other 15 are post-transplant in complete remission. And then you've got these other 6 who, at the present time, are well. So I think this data does clearly suggest, given the very poor outcomes that we see trying to transplant children who've had HLH, that there is a reasonable rationale for preemptive transplant for these conditions. So, do you want me to stop, or do you want? I've got 3 or 4 more slides. Just, I don't mind if we're a shorter time. Okay. So, I suppose another way of looking at this is, at the moment we've talked about transplant for HLH. but I started by saying we should be thinking about tailoring treatment towards individual diseases. And I think XIAP deficiency or SIAP deficiency is a really good example of this. Not that we've got the answers to it, but so this is the original description of transplant in SIAP deficiency, which showed really terrible outcomes if you were trying to transplant the patients when they weren't in remission, and really awful outcomes if you were trying to transplant them using myeloablative conditioning. However, on a very small number of patients, it was either 7 or 9, I forget, you had a good outcome if you were in remission and you had reduced intensity transplant. Now, compared to most of the other forms of primary HLH syndromes, we know that the pathophysiology of SIAP has probably very little to do with cytotoxic granule release and is probably multifactorial. It's probably more akin to some of the inflammatory disorders with excessive inflammasome activation, increased susceptibility to apoptosis, and an inability to efficiently respond to innate pathogen recognition signals. So we know that there is a slightly different mechanism that's initiating this inflammation. Last year, the Japanese published some excellent survival data using reduced intensity conditioning. However, they used quite an unusual conditioning regime using, well, certainly from our perspective anyway, low-dose TBI included in with a reduced intensity conditioning regime. And what they found is they had, although they had very good overall results, they had 4 out of 10 of their patients developed HLH relapse after transplant, many of which did so really quite early on. And this, again, is something that we've seen in some of our patients. So trying to put some of this together, we've put together another international survey going to as many centres that have treated at least a handful of patients with SIAP deficiency and using reduced intensity conditioning to look at outcomes. And overall, the outcome of this disease seems to sit there, that's right, at the magic number just above 60%, like just about every other survival curve on any of these things we've looked at, which is obviously better than we were seeing before, but still lower than we'd want. However, what we found is that there were quite high levels of more severe graft versus host disease with this condition. So if you get GVHD, there's an increased proportion of patients who are getting grades 2 to 4 GVHD. And when you look at the survival, looking at those who either get no GVHD or grade 1 GVHD, it's much, much worse once you've established this. And this would fit with the pathophysiology of the condition. This is ubiquitously expressed protein that we know has lots of inflammation in the gut and other areas. Interestingly, gut GVHD in particular didn't seem to be a major problem. And actually looking at a sort of very basic multivariate analysis, the hazard risk of developing grade 2 to 4 GVHD made you almost 5 times more likely to die from a transplant. We didn't really see, interestingly, the HLH relapse levels that we've seen when you've expanded that out outside the Japanese group was very similar to that seen in other conditions. So, just bringing all of this sort of together, I think rather disappointingly, I think from many respects, I don't think we are much further on than we were 10 years ago in terms of transplant outcomes, which is disappointing considering how much further on a lot of the rest of the field's gone. I think it is clear, almost everybody would agree that submyeloablative conditioning is optimal, but actually the sort of degree of ablation and exactly what sort of serotherapy and the timing of it remains unclear. I think we have some more clarity around what sort of levels of donor chimerism are curative, and I think what the risks are of sitting tight with low levels of donor chimerism. I think different groups and different individuals would intervene at different levels. And I think we do have clarity over what to do about asymptomatic siblings. But I think my main conclusion would be that I think pre-transplant management and tissue repair and a really efficient switching off of the inflammatory process before you're getting going, I think is probably going to be the most important thing. And I think the asymptomatic sibling data actually emphasises that. What we ideally want to do is try to get these patients back to being like their asymptomatic siblings. Thank you.
So are there any questions for Austin before we go to the tea break?
Yes, quickly. I'm Frances Nicola, I work for CB France, the company. Can you tell me how long do people actually wait for their transplant? So is there an average waiting?
That's a very good question. I'm sure that's very different in different places. I think the reality for most units is it's a pragmatic decision. We try to get children as de-inflamed as possible, and then Anu was showing in detail the post 8 weeks stabilisation period where we're using cyclophosphamide and pulse dexamethasone to try to keep people stable. In theory, we could go at any point in that time period. That would be our ideal element. The practical reality of trying to set up a transplant in an 8-week period is quite challenging in a busy unit. So I know some centres do go in earlier, and if they feel they've switched it off, I do know people have transplanted even before 8 weeks and going straight in. And interestingly, we haven't really talked about the French approach to this, which is using Campath and ATG, and they've actually got as good data as the early novimmune data using Campath. It's really, certainly when we saw it a couple of weeks ago, it's really very, very impressive. And what they do is they slug a load of serotherapy and then go in as quickly as possible.
Well, they go in caploads, yeah, which with some centres are less.
Yeah. Well, that's a very good, really enjoyable talk. Have you changed your practice with regards to cyclosporin now, given that the HLA 2004 data is not much better?
So what we do is that we don't go in up front with cyclosporin. And if we're losing, if we're not winning with conventional therapy, then we will have a lower threshold for adding it in. We would usually think about adding in a biologic agent at the same time if we're in that sort of situation. What we have started doing is we've generally tried to add in the cyclosporin at a safe time later on down the road, so that we've had a good chance to see cyclosporin before we go into the transplant. Because of the high levels of press that we've seen with these patients, it's good to make sure we kind of get the exposure out of the way, so that we don't get a nasty shock around delaying a transplant or something like that. And I know since that's Cincinnati's approach generally as well with these sorts of patients, and I think a lot of centres are doing that, but others still go in cyclosporin up front. And I think you can argue it either way. But
well, can I suggest that we have a shortish tea break here now, go and have a comfort break, there's some cakes and tea outside, grab them, come back in, and we'll aim to start again at 25 past?
5 minutes.